I am a solo orthopedic hand surgeon and founder of Trinity Hand Specialists in Johnson City, Tennessee. Incidentally, I've been an AAPS member for about 20 years and hope to be so for 20 more. My hometown of Johnson City is about 65,000 folks in the 500,000 demographic area of what's called the Tri-Cities of Johnson City, Kingsport, Bristol, and suburbs. 7 years ago, this spring, I left a large orthopedic multi-specialty group, mainly to have an office base more for hand patient care and to get out of the stressful level 1 trauma care. I also enjoy, Kevin, sleeping at night now and having my weekends more freed. As far as I know, I'm the only opted out surgeon from Medicare and Medicaid in my region. Now, earlier today, Dogbert was originally offered just a 5-minute driving instruction class at Fred's driving school at another part of the hotel. Dismayed by this and having a little more time on his hands, he came to join us today for this one-day course. In this talk, I'll quickly, but not recklessly, summarize a third-party opt-out strategy to build a more independent and healthier practice by just debreeding all government payers first, an incremental approach, I call it, and I'll simply refer to this as opting out in the presentation. I know that more surgeons are now beginning to opt out of Medicare and Medicaid, or are at least considering such. But it's my hope today to help any physician desiring more transparent, fee-for-service patient care to thrive, not just survive, and to not crash while doing so. So, as has been done in other talks, let's discuss the what, why, how of doing this. I'll first review some of my business practices. This will set the stage then for explaining some motives for opting out and firing some commercial payers. I'll then share some observations from doing so. Then, from her experience in managing my billing and collecting, I'll conclude by having my wife, Debbie, give you some tips, traps, and tales from the often hostile front lines of hand-to-hand combat with commercial and work comp third-party payers. Incidentally, I have no financial conflicts or inducements to disclose, and I'm here at my own expense. I will mention on workman's compensation, and we'll look at this in a moment. It's a good bit of my practice, and focused on occupational injuries and care of these patients is a particular challenge to those of you who might also share in the care of these patients with me. Back home, I am very blessed to have a wonderful medical family shown here. I have 6 paid employees that increase my quality of life, efficiency, and everything done clinically for my patients. There are 2 salaried certified hand therapists, one of whom has his MBA and serves as my administrator. He also doubles as my bodyguard. And 2 each of hourly clinical and clerical staff. My wife, Debbie, is an unsalaried 7th volunteer, or perhaps willing indentured servant, depending on who you talk to, especially when patient statements are going out later in the month. Billing and patient accounting take her about 30 hours a week, but her most help to me is carefully scrutinizing every claim. My best resource is not people, it's absolutely the right people. The administrator oversees marketing, insurance contracting, and human resources. He's also on our state's work comp advisory board and is part-time in hand therapy. He does a great job of helping me remain objective with all fiduciary decisions. Importantly, he communicates without colluding with other administrators, medical practice administrators, locally, statewide, and nationally, particularly through Medical Group Management Association, or MGMA as it's more colloquially called. It's also very important for your business manager or administrator to participate and be a member of that, and to participate in the annual salary and practice surveys. Those dashboards are not available to you unless you fill out the surveys. I work every day out of 4 exam rooms and a minor procedure room. The office also includes a conference room and a hand therapy suite in a building just a few blocks away from 2 of the outpatient surgery centers where I do most of the work. Now, I'll read that caption. The nation's healthcare system continues to become more and more specialized. That's a splinterologist for those of you who can't see up there. Although I do remove several foreign bodies from hands every month, and hand surgery might seem like a narrow surgical niche, my community-based peers and I in the American Society for Surgery of the Hand actually treat a wide range of upper extremity traumatic and atraumatic conditions. However, as said by Dr. Huntoon, my practice is more limited to the hand and wrist. At Trinity Hand presently, my practice mix is about 5% self-pay and privately contracted Medicare. I don't see Medicaid patients, at least on a contracted basis. I still have 20% work comp, which is what I had in my orthopedic group, and I'm now at about 75% commercial payers. But keep in mind, and we'll look at this in a moment, some of these 75% are actually Medicare patients who have other health plans. Since I really enjoy taking care of these work comp patients, I'm probably never going to be completely opted out, and I'll go into that in a little more. So in transition from my 2005 orthopedic group, where I'd been for 15 years, although I picked up a lot of indigent trauma on call, it was such a negligible percentage of my practice. Commercial carriers were about 60 to 65%, and as I stated, work comp was still 20%. But like others that have opted out, commercial payers eventually fill in the governmental gap. For me, it was immediate, but planning for a several-month transition is prudent for most. Contracting and self-pay pricing for office visits, of course, are done by time. My hand therapists also bill, and then surgery is done per usual CPT guidelines. So I do all of this in an empirical, not an emotional way, to avoid the double jeopardy of signing poor contracts and displacing other patients with better coverage. So let's examine how I've chosen to do this in the next slide, and with more detail about how charges are generated in a surgical practice and how costs can be known, particularly in a paradigm where you're still trying to keep up with these little boogers. The RVUs, as Dr. Huntoon mentioned, have been around for almost 20 years now and are part of an 8-part formula for how medical services get paid. This slide just graphically demonstrates that contracting can be analyzed with reimbursement as a percent of Medicare. I use 2011 since I'm just dashboarding my practice from last year. I've filled in a few of the payers so that I can show you where I came up with these averages in my state and in my practice. My work comp contracts are by far and away my most profitable payer. So all of the commercial payers are somewhere around 160 or so percent of Medicare. I have to know, as do you, if you're going to look at your practice this way, your floor, your bottom line for costs and practice expense. These are calculated per payer by knowing the total number of RVUs, and my practice software keeps up with this, per payer. So presently, all of my payers, as you can see, are pretty well scattered inside this lightly shaded triangle. And it's okay to volume discount like any business, accepting less reimbursement for higher numbers of RVUs seen. And of course, it'd be better to be over in here, but as you fall down into this area, you're getting to a point of diminishing return because I don't want to be that busy, number one, plus you're beginning to hit some marginal reimbursement. The diagonal red line just approximated my best and worst carriers, and in general, it's better for me to stay closer to that line. Since the statutory Tennessee work comp fee schedule and several commercial carriers are already contracting reimbursement as a percent of Medicare, this is a more exact way for me to negotiate and to analyze my practice, basically knowing when to hold them and when to fold them. We scrutinize all payers at least every 2 years and terminate any that are too onerous to deal with and/or who just want to reimburse too little. Commercial reimbursement contracts do change while in force because of the annually fluctuating Medicare reimbursement conversion factor, part of that 8-part formula, which has now declined to $34 per RVU from $38 7 years ago when I started Trinity Hand. Now, some contracts will specify payment to be as a percent of current Medicare rates, but it's far better to get a rate negotiated that's locked in and cannot decrease, say 140% of 2008 Medicare, for example. Now, based on my total annual operating expense divided by my yearly work product in total RVUs, $47 per RVU is my break-even point. I average about 15 new and 35 established patients and do about 20 surgeries per week. But in contradistinction to a lot of orthopedic hand surgeons, in this country at least, a third of those surgeries are actually done in my office now under local anesthesia and wide-awake surgery. This is vastly more convenient and inexpensive for my patients, particularly my self-pay patients who are saved that nefarious facility fee. And there's up to 40% reimbursement from some payers better than at the facility, which would be the hospital or the ambulatory surgery center. So billing out of my office is considered non-facility reimbursement, and there's often with these payers a 2-tiered reimbursement schedule. For office visits, as I implied earlier, I just bill for my time as allowed by CPT evaluation and management guidelines, if the note just documents the face-to-face patient time. Particularly for the complex second opinions and independent medical exams that I do, it's not uncommon, as others have spoken, for me to spend up to 90 patients or even more with some of these folks, because building mutual trust with a confused, frustrated, and sometimes multiply operated on patient takes a lot more time, particularly in the work comp system. No-shows often happen when somebody else is not paying, so I insist on pre-scheduling payment for complex work comp patients in protected time slots. I work an average of 60 hours a week, 70% of which is in the office seeing patients, 20% in ambulatory surgery centers, and about 10% of the time in my own office operating room. And I take about 5 weeks off a year. Presently, my overhead is at 55% of revenues. By choice and for much convenience, I also fully enjoy a completely digital and almost paperless office with electronic charting and scheduling software and digital x-ray processing and archiving. By MGMA benchmarking, though my income is very average for a full-time general orthopedist, all of my employees' salaries and benefits are at or above the 95th percentile. Now, digressing a bit, while preparing this presentation, I was reminded of the peace of mind that has come from not fighting daily with the feds over healthcare decisions and the more tranquil distancing from their statutory criminalization and unconstitutional overregulation of medicine. But some days, more than others, this serenity is increasingly being challenged by commercial payers with whom I'm admittedly still in a love-hate relationship, and who need as much vigilance as an undisciplined toddler. A little more about why I opted out. When initially deciding to opt out as a soloist, I realized that even cursory compliance with burgeoning Medicare regulations and probable future audits would detract too much from my patient care. So I followed the sage advice of Edmund Burke: better to be despised for too anxious apprehensions than to be ruined by too confident security. We physicians must continue to work smarter, not harder, and we've heard a lot about that in this forum today. Having a responsibility to keep redeeming and reforming the time in our God-given vocations and to be more faithful stewards of what has been entrusted to us. In the interest of time and avoiding redundancy, please also refer to the talk given last year at this meeting by Dr. Giannoli about how he did opt out of all third-party payers, somewhat incrementally like I did. In that 3-part YouTube video, he does comprehensively address the usual inhibitions and objections to more fee-for-service care and explained well his own practice analysis method. So then, as we try to stay on track and do what's right for our patients, We must be vigilant without being vindictive, and labor against and not just lament the commercial and especially federal bullies trying to knock us off the tracks. For decades, these socialist cartels and their governing aneptocrats have increasingly been trying to usurp our decision-making in the exam and operating rooms across America. Not sure who came up with this, but my retired ear, nose, and throat surgeon uncle, who's retired up in Wyoming, sent me this recently. Ineptocracy, a system of government where the least capable to lead are elected by the least capable of producing, and where the members of society least likely to sustain themselves or succeed are rewarded with goods and services paid for by the confiscated wealth of a diminishing number of producers. Amen. Let's look now at some of my personal observations about opting out. Most Medicare, Medicaid patients in Tennessee will go elsewhere upon learning that I'm opted out. An economic choice, not necessarily based on their standard of living or my practice's aptitude, availability, or attitude. These are patients who are not usually committed to our practices anyway. Case in point, family practice friend of mine tells my administrator that upon opting out last year for his ambulatory care clinic, he had some of the more disgruntled patients come in, only to find out that some of the most incredulous were not even his patients. They brazenly asserted that they just came to see him when they couldn't get in to see their other doctors. Now, most are very loyal. And established patients of mine, before they went on Medicare, are more likely than new ones to privately contract. Now, the next point is very important. I've come to find out that many Medicare patients really do have other third-party payers that they can use only because I am opted out, through retirement plans, work comp because of on-the-job injuries, a working spouse's health plan, or their own employee's benefit, or their own employee benefits, plural. As many retirees aren't anymore and are still in the workforce. Medicare folks in Johnson City will often wait much longer for appointments with other docs who do limit Medicare volume in spite of my not refusing or limiting them, since I can privately contract. Now, I make no apology for opting out, and all of my staff are trained to charitably refute the entitlement arguments by just agreeing to disagree charitably without being disagreeable. After the shock has worn off that my office really does not accept any government payers, the more incredulous patients are counseled by my administrator. Eventually, this contentious incredulity usually just gives way to some irreconcilable frustration, and they're thanked for the interest in my practice. My staff handle nicely, though, most routine self-pay inquiries, but training and scripting are necessary, along with a low threshold to refer the more skeptical and talkative folks to administration. All of my opting out info must be read. It's either on my website or we hand it out at the office, and agreed to before the day of the visit, avoiding taking up valuable clinic time defending my position. Since Medicare can still be billed for just the initial care of Medicare emergency problems, the Medicrats obviously don't think that follow-up emergency care is important, so you can only bill for the initial date of service or service provided. For the first couple of years, just went ahead and tried to send those claims into my third-party administrator. But the hassles far outweighed the modest reimbursement. So now it's just easier to write off the charges for the few routine ER-referred Medicare, Medicaid patients that I see each year, particularly from this small rural hospital nearby where I maintain my active staff privileges and help them with their ER coverage. Furthermore, ineptness is not the sole domain of CMS either. Our regional Medicare third-party administrator has even given us patently illegal and contradictory advice to balance bill a Medicare trauma patient several years ago for initial care when the TPA refused to pay for that care. You can also be opted out if you're in a group. I've not heard that mentioned today, but you can. But such would obviously require a good deal more planning and conversations with your partners and staff. I know by now that most of my referring docs really do send many Medicare patients elsewhere, but some of these folks actually wind up coming back to my office anyway through other word-of-mouth referrals. As a specialist, I've found that referral sources do need frequent reminding that Medicare folks can still be seen via private contracting, and that I opted out of Medicare and didn't opt out of caring for Medicaid patients. Blessedly, most of these docs have continued to refer their patients with other third-party payers, however, and interestingly, I now treat more arthritic and other conditions in the retired population than I did when in Medicare and the ortho group. So in closing, and after weighing everything in the balance, I hope that you can just move on. And per the subtitle, just know when to quit some of these payers. And if we're going to do the best for our patients by our own AAPS motto, we must understand the times in which we render care and the context available to us in which to deliver such most freely. The unwary doc, like Hillary here, is just oblivious to unseen threats. But the foolish doc ignores known threats and had better be tough. Do not underestimate the unlimited resources and force and insatiable appetite for power of our government, nor should you misjudge the commercial payers' premeditated tenacity to delay, deny, and don't pay. So after planning and networking with others in your area of similar or like specialty who have opting out experience, above all, don't sacrifice your convictions at the altar of apathy, frustration, or procrastination. Very few physicians in America can be covering their practice overhead with Medicare reimbursement, and the majority of docs just feel trapped in the government payer system for one reason or another. I fully realize that opting out is much harder for some than others, but it's been the right thing to do for my patients, practice, and me. And none of us can muster an equitable defense against the heavy-handed bounty hunters and tactics of CMS if we're in their crosshairs, or their rack-pack bounty hunters ride into your parking lot on several of these street bikes. The sun is now set on my part of this talk. I appreciate your attention this afternoon and bid you happy trails into the greener pastures of opt-out land from the front porch of my farmhouse. And I hope that if some of you are sitting on the fence, that you will really consider opting out of the government payers first. The Trinity Hand website has more about my opting out and private contracting, and all contact info is there too. The AAPS website, I will reiterate, however, is the best place to start this journey, coupled with membership in AAPS, recruiting other members, and contributing to our PAC. I'll now introduce Debbie, my wife of 31 years, who's taken some leave from her patient accounts desk to share with us some firsthand billing experience. Before raising and homeschooling 3 children, her background was in computer science, math, and bookkeeping. She's a self-taught killer biller, as I often call her, a fiduciary spy, sniper, and soldier when it comes to maximizing my reimbursement and minimizing third-party fraud, theft, and outright abuse. Now, as laughable as some of the excuses are at Garfield's health insurance company, Debbie can attest that these are not stretching the truth about real third-party tactics, some of which we've already heard about today, to delay, deny, and don't pay. Please welcome her with your attention for just these next few minutes.
Well, I have to say that this is one of the most difficult things I've ever tried to prepare for. I'll keep it really short, and I've totally changed everything that I had prepared based on what everybody else has said. But I'm not sure I appreciate the opportunity to get to work with Paul after being home with kids for 20-some years. And I do really appreciate everything that he goes through every day to provide excellent health care to his patients. Not sure I appreciate him asking me to do this, because I never could have imagined how difficult it would be to give you a picture of what it's like from my side of things in 5 minutes. So I'm going to ramble, and if you have any questions that you think of from your practice, especially for the people that are just thinking about opting out of Medicare, I have to tell you, when Paul came home and said he was going to leave the security of his big group and start this hand surgery practice, I was really nervous, but I was even more nervous when he said he was going to dump Medicare. But it's turned out to be a great thing. We've learned a lot of things about dealing with it, and it was a great decision. So if you have hesitations, we have taken an incremental approach. Insurance in our area, third-party prepaid health plans, which is what it really is not so terrible from all payers that we've opted out of those payers yet. We have dropped some of them, and we do reevaluate it every year. And I think, that's a good way to approach it if you're afraid to just go cold turkey. And we have had, just as an example, 2 very large insurers that we dropped contracts with because the payment was so low that we since have reinstated. If a lot of you who are individual physicians or smaller groups, you might have something in your area called an IPA, an Independent Physicians Association, which we actually do contracting for a large number of our insurance contracts through that IPA. It gets us much better reimbursement than those insurance companies would ever give us on our own. And it has made it possible for us to get back in with a few insurance plans that we had dropped. Secondly, the IPA, when you're ready to just throw up your hands and say, this insurance company is impossible to deal with, the IPA actually has a lot more clout with an insurance company. In addition to, I would second what Andy or somebody earlier said, the patients. The patients have a lot more clout with their insurance company. So the things that we've done that make it successful, first of all, because we have eliminated the government payers, we do have a set price for self-pay. It makes it easy for us to see self-pay. We can discount those services. We don't have to charge our full fee, just like when we contract with an insurance company for fees below our stated fee that we bill. We also have a self-pay contract, and we have set fees when somebody calls and makes an appointment, Medicare or otherwise. We can tell them exactly how much an office visit's going to be for a new patient, an established patient, how much an injection will be, x-rays, et cetera. And we've just, we've based that on averages just so that we can have a set fee. Surgeries also are calculated based on RVU and our cost for doing business. When you do your contracts, 3 things that we have learned about the contracts is your relationship with an insurance company is only as good as the contract you have with them. We've learned the very hard way about assignment clauses. We would never sign a contract with an assignment clause. And if you're not familiar with what that is, it basically means that a payer can buy the fee schedule that they have established, that a carrier that you're not contracted with can buy a fee schedule from somebody else and use that to pay you. And it's like a silent PPO. And what happens is eventually, it may take a few years, but eventually you will see all of your reimbursement at your lowest contract rate. So we would never, ever sign a contract with that. The other 2 things, we would never sign a contract that does not give us changes in writing and allow us to either accept or decline in writing back to them. And the third thing is we insist on a termination clause of 30 days with cause and 90 days without cause. That way, when we determine that we just can't play ball with that company anymore, we have a way out and we don't have to go through. So what makes insurance acceptable to us right now, weighing the risks of dealing with all their requirements and the extra staff, is that we get our claims out, we get them correct the first time, and we get paid quickly. So it's similar to a cash practice with a lot more potential for hassle factor, but 95% of our claims are paid in an average of 15 days. The 5% are the ones that sometimes you just want to say, why am I even doing this? So it's just a goal in our practice to, we don't reinvent the wheel every time. We get the patient involved. The minute I find out an insurance company has said that they've pended a claim for some reason, the patient is notified, and we put a lot of work on the patients because we don't have the staff or the time or the inclination to deal with the problems. And part of that is educating your patients about insurance. A lot of the previous speakers have said that patients don't understand insurance. That is so true. And I didn't understand it until we got our high deductible policy. Then I became a much more savvy consumer. So I say bring people with more high deductible policies. They're great because they understand what's going on a lot more. I think that's all I have time for. Please feel free to ask. I can give you lots of suggestions. I have lots of letters for appeals that are already just set. I've probably seen any frustrating experience that you've seen and have worked through it. And it really, for the most part, has not been a bad experience with the commercial carriers that we have left.